Welcome to the Shift Report, the podcast from MCentric and the MCentric Foundation. MCentric is the go-to information and resources hub designed exclusively for the emergency medicine community. We regularly host key leaders from the field who share their insights and experience. Our goal is to inform our listeners and to encourage you to use what you learn to improve your practice and improve yourself. To learn more, please visit us at mcentric.org. Today's episode is sponsored by Lotus Clinician Wellbeing. Lotus Clinician Wellbeing provides consulting services designed to prioritize clinician wellness in order to provide the best care for their patients. Lotus Clinician Wellbeing supports healthcare professionals with personalized coaching and consulting services for groups and individuals in areas such as career development, leadership, burnout prevention, practice management, and more. For more information, visit lotusclinicianwellbeing.com. Today, we welcome Kim Tranquada. Dr. Tranquada lives and works in Tucson, Arizona, and she has a collection of interesting ventures that she has developed and worked on, including the Healthcare Alliance for an Equitable World. She's going to share more about that very interesting work and its mission aimed at impacting equitable access to high-quality healthcare around the world. Welcome, Kim.
Thank you. It's wonderful to connect with you and your audience, Til.
Thank you. And thanks for taking the time. I know that everybody's busy, and thanks for taking the time to share what things that you're working on and a bit about yourself. So we really appreciate it. I always like to start out with how you got to where you are. You're an emergency physician, and everybody got there with a little bit different pathway. How did you end up doing what you're doing in emergency medicine?
Yeah, sometimes I don't even know how I got here myself. I pinch myself. So I immigrated from Guyana with my family when I was 7 years old to the South Bronx. And as a first generation immigrant, I really didn't know what my life or future was ever going to be like. But I decided to pursue medicine. And I thought I was going to be a pediatrician, actually loved kids. And once I got the emergency medicine bug, I was able to, I went to med school at Downstate in Brooklyn, and we had a ER rotation for med students. And boy, once I started doing that, it kind of ruined it for everybody else, right? This has happened in my career as I've trained students and residents too. Just the ability to see anything and everything that walked in the door, to resuscitate people. When I trained back then as a med student, I could do stuff. I mean, we were doing central lines and invasive procedures, and it was just amazing what we could do for people. And in Brooklyn at that time, just the things that you saw coming into the ED was incredible. And I was hooked. I've been on a career path of being really proud of what we do in emergency medicine as the social safety net for everybody and everything. But also at a point in my career where I want to do more and not just be the safety net, but maybe change some of the things that make a safety net necessary.
That's great. I think we all recognize whether we intend to do it or not, we are the safety net for many people, and you've really lived that. You have the pathway from Guyana to New York to Tucson is different. I haven't heard that one before. And I'm sure that pathway influenced what you're doing now, probably in many ways.
100%.
So tell us a bit about the Healthcare Alliance for an Equitable World, HAEW, and how it started and what you do.
I appreciate that. So, everything in life happens because of what came before. I think sometimes I speak to younger docs that are considering entrepreneurship and wondering if they're ready. And just know that when you're ready, it comes to you, and every life experience leads to the next thing. So, during COVID, I had the opportunity to really do something out of the box and invent tele-emergency care from the ground up within the VA healthcare system at a large scale. across a whole network, 3 states and 8 hospitals. So I started that first program in 2021. And after seeing what we could do connecting with patients in their home from a phone call to a call center within 10 minutes and how we can impact people's lives. I mean, most of the time, we learn a lot of things we are not even learning in the ED now, like what keeps people from ending up in the hospital, the transportation issues that they run into when they just can't go to the hospital, where they can't get prescriptions. I mean, we deal with things that even in the ED, and we're the safety net there, that we haven't dealt with. A whole new dynamic in how to care for patients in their home instead of at a medical center. And of course, getting people to medical care at a medical center when needed. And also using this kind of interesting staffing model where we used ED docs from all these different facilities to help patients kind of as part of their ED work. They would do a dedicated shift in telehealth. And I decided that I thought this was great. I did it again. I actually built it in another 5 states, and I thought this was great. And it's now a national program. And I said, this is great. It should continue. But what skills did I just hone and grow? And how can this really fully grow to impact the world? And I decided to start the Healthcare Alliance for an Equitable World because 78% of the world's doctors are currently treating only 16% of the world's population. And as much inequity as we're seeing here in the United States, we are actually living in relative healthcare abundance. And imagine if we can bring this really fulfilling work, because everybody that does this work loves it and they're super fulfilled. And this is kind of fills that little bucket that everybody's looking for right now of meaning. Um, what if we could all do this work very accessible from our home, but actually connect with that 84% of the world that doesn't have access to our medical expertise and really make a giant impactful difference. And that's why I started the Healthcare Alliance for an Equitable World. Sometimes I laugh, I pinch myself. That is a big, giant vision, and I am one little person, but that's okay. I think I felt that way 4 years ago when I started building teleemergency care. Girl, how are you going to do this? You do it by connecting with people. You do it by inviting people into your vision and your mission. You do it by building community. And that's why I'm here chatting with you today, Til.
So that's a great story, and I think I'll repeat that statistic you said and let it sink in a bit. That 78% of the physician workforce accesses or treats 16% of the world's population, meaning that 84% of the world's population has little to no access to healthcare. That's a very, very big number. And yes, you are one person, but you're one person with a skill set that, you can fix this one person at a time or one place at a time. How is that growth going, and how have you taken the lessons you learned from operating in the VA system, which is big enough to start with, the largest healthcare system in the US, to to really trying to solve a problem that is very basic around the world?
Yeah. It's messy and it's fun and it's going. So in our first year, we partnered with one of the most well-established tech companies here in the US called VC to do hybrid in-person and telehealth clinics in the Philippines. So they were also growing their platform to be able to work in low-resourced communities, and were doing these clinics 2 or 3 days in rural areas of the Philippines. I mean, really purposely picking low-access rural areas to provide healthcare. And they would recruit a couple of docs from the community, often, two doctors or so from the community. And we and a couple other telehealth companies supplemented them by working on telehealth. And we've done that 6 times in the Philippines in a year, treated over 1,000 patients. And what we learned is that this is an amazing healthcare workforce expander. Since then, we've partnered with another nonprofit, also started by a physician, called Global Telehealth Network. And they have worked through Rotary International and IEEE with the International Engineers Society Smart Village to develop a program in eastern Uganda, western Kenya, so right across the border from each other, where we are gearing up for February to deploy telehealth across 3 rural hospitals, 4 rural clinics, and 2 rural boarding schools. How this is working is IEEE has helped put solar in each of those places, so there's reliable electricity to run the telehealth platform. VC, our partner that I told you about from the Philippines, is providing their telehealth platform, and Global Telehealth Network is providing laptops. So even if we never show up there, we have now interconnected those sites in a way they have never been connected before, and created a telehealth infrastructure, at least for supporting each other in that rural area. On top of that, what we're going to layer is our Healthcare Alliance, HAEW, ED folks to consult in real time with the local healthcare provider. Oftentimes in a rural clinic, that's a nurse. Nurses are licensed independent clinicians in most of the rural areas that we're talking about, and they actually have prescribing power as well. Not to mention prescriptions aren't necessarily used for medications, but
Right.
we can consult in real time with the nurse to either help them stabilize somebody that's unstable, or if we decide that the patient's stable and what they really need is a neurologist, a cardiologist, some sort of specialist, and they can wait sometime between 2 hours and 24 hours. The Global Telehealth Network has a network of specialists that will connect them to, that will give them a consultation in the next 24 hours, not necessarily live with the patient. So in a consulting manner, again, extending the healthcare workforce that exists, because that is a huge chasm. Training is absolutely ongoing in much of the developing world to increase the healthcare workforce. But you and I know that to train a physician is a 3-decade process. So to catch up on the huge chasm that we have now is not going to happen for generations. And people are suffering, right? Look, human suffering is the cause for economic issues, is the cause for political instability, is the cause of political distrust, which leads to conflict. I really think we can get to the root cause of helping decrease human suffering by just sharing what we have through very simple connection like the one we're using right now.
Yeah, this is a great mission and a great story. You've gone from talking about the Philippines to the border between Kenya and Uganda, and I'm sure people have to pull up a map if they don't quite realize. And these are also difficult areas to get to. Let's talk a little bit about some of the non-medical aspects, which are interesting in this, because in order to bring this, you have to come up with partnerships for simple things like power, which many places don't have reliably, and connectivity of some kind, whatever it may be. You and I don't know what your situation is in your home or mine, but we both have high-speed broadband, so we can easily talk to each other. The rest of the world, not so much, whether it's satellites or fiber or whatever it is. And how do you put together the partners that aren't medical per se to provide you with that support? What are the incentives for them? How do they, and talk a little bit about how that improves the rest of the economy and the social structure in those places, regardless of what you do.
Yeah. So public-private partnerships are the name of the game here, right? So we not only have to partner with people like VC and IEEE to put in solar and Global Telehealth Network, but we also have to partner with local governments, right, and local ministries of health to make sure that um, we are not running afoul of any of their regulations, that we are practicing within the bounds of what they consider practicing healthcare versus consulting healthcare versus telehealth. So we definitely have to do a delicate dance with that. I have to say, when I entered this, it's only 2 years old. 2 years ago, I was so pleasantly surprised that when you talk to CEOs of big companies that do have the ability to do these things, they're interested. They're interested because, of course, it's a new and different market, right? It helps them develop their products to be able to serve a different market, right, outside the United States. And there's a lot of companies that have a social entrepreneurial side of their company, right? So they make money, but they also want to carry out service. So that is a lot of how we have formed these relationships and will continue to form and grow these relationships in order to deal with all of this logistics, right? There's lots of logistics. What this does is bring resources, right, to places that their concerns might not be visible and their needs might not be visible because now we are there. We've given every clinic a list of supplies that we need, basic emergency supplies, so they'll all have that now, if they didn't before, to make sure that we can carry out basic life-saving interventions in a timely manner. What we're going to learn is what do people need in terms of transportation. Ambulances are not very common, actually. Most of the time, people will travel hours either by, if you can find a car, or a motorcycle or a moped. So you've got a broken hip or a broken femur, you're going to be on the back of a motorcycle going 4 hours trying to get to hospital. So what we will bring over time is also visibility and resources to help improve the healthcare infrastructure for the communities that we serve.
I'm sure you're learning lots of lessons, and I think that those of us who largely practice in the United States and are used to having resources and are used to having an ambulance or a helicopter or something, even if you practice in a rural area, people have cars and there are ambulances, and absent weather, there's helicopters. The thought of transporting somebody with a painful injury or a critical illness on the back of a motorcycle for some number of hours seems almost unreal, but it's the reality in these places in the world. What are some of the lessons you've learned, hardships you've faced, things you've had to get over that maybe you didn't expect? I didn't really prep you for this question. There are things in the world that are just mind-boggling for to an American who hasn't really traveled very much. But you're now operating in places that are very difficult. What are some things that people are going to hear that maybe they don't think of that you faced?
So I'm going to do two parts to this. First of all, I also work critical access, Indian health, and really try to be a rural health specialist and immerse myself in rural health here in the United States. And I've seen some things in
Yes.
that environment that I think most emergency medicine physicians don't understand. We already have a perspective problem between urbanized tertiary care centers and critical access and rural healthcare centers. Um, every time I work in a critical access hospital and I have to call a tertiary care hospital to take a patient, I have to spend half of that transfer time explaining that I am the only doctor in this hospital, that no, we don't have surgery, no, we don't have OB/GYN, no, we don't have an ICU. And that is why the patient has to come there, because everybody is under their own pressures, right? Everybody's overcrowded. And we have taken the healthcare system. So we have the 78%, right? But they're not actually spread out evenly. They're all concentrated into smaller and smaller environments, right? So you have your urban tertiary care center that has to take all the patients because they have all the specialists and all the special equipment, and then they're overcrowded. And they also don't have any perspective of what's going on in the periphery. So this is a distribution problem, even in our very well-equipped healthcare system. And I'd just like to invite people to have a little perspective that the way medicine is practiced in a tertiary care hospital is not how it can be practiced in a critical care and a critical access hospital, where people don't want to take an ambulance because they can't afford even the copay, where they can't travel because they don't have transportation. All levels of similar to these issues we're going to find in less developed, less resourced places in the world.
I think one thing I'll throw in, one thing that I've used as a teaching tool, and this is perhaps useful for those that are teaching faculty who are in tertiary centers with every specialty known to man in their tertiary facility, presenting scenarios to residents about what would you do in X situation. And inevitably in this day and age, they talk about which consultant they need. And I like to occasionally throw in, okay, you're in the middle of Wyoming in a snowstorm. Nobody's driving and nobody's flying. Now what are you going to do? And I think that speaks, that's a very oversimplified version of what you're talking about, but that's the reality in many parts of the country, and a reality I am certain you faced.
Yeah, it's a reality in many scenarios and not just a big snowstorm. So just I think it's important that we all kind of open up and share those perspectives. I don't blame anybody for not knowing what they don't know, right? But I do think this community that we're building, you're building a community, I'm building a community through Healthcare Alliance, through the Voices of Healthcare podcast. To this community helps people kind of open up their perspective to see more of what's happening, not just in your country, but what's happening in the world, what's happening in our healthcare community globally. Because I'll tell you, if we don't connect outside of our ecosystem, we are not availing ourselves of the greatest tool that we have. I don't think I would have been able to do the things that kept my staff alive and protected in terms of PPE and taking care of patients during COVID if we didn't have international colleagues posting what they were experiencing, what they were doing, how they were overcoming PPE problems, how long you can, how to sterilize your PPE, how to do this, that. These were not things that were coming to us through official channels. They were coming to us through our own international colleagues sharing their wisdom. And I don't think we should go back and forget that. I think we should amplify that and move forward, because we have big challenges that we could solve better if we're all connected. But in terms of stuff that I've dealt with overseas, look, it's really hard, I think, and as we talk to people who might consider doing this work with us, you have to be really humble when you're doing this work, because you can't do everything and you can't get patients to everything, but you can give them your advice as to how it could be treated. You can invite them to be part of deciding what they can and can't get done. Um, and I had to treat a young lady that was trans in the Philippines, where it is actually illegal to be trans, and you could be imprisoned. And she was taking um, street hormones to help her live the identity she wanted to live, and having side effects, and really was talking to me, asking about those side effects and how to manage that. As an ER doc, that is not my level of expertise, but it is more than she was ever going to get. That I could talk to her a little bit about the effects of estrogen, and to treat her as a human being with respect instead of a criminal that needed to be thrown in jail. Was it frustrating to not be able to refer her or get her the services she needed? Sure. But I could make a little bit of a difference. I could give her a sense of her humanity and the sense that she is normal and not expendable. So there's challenges. There's always going to be challenges, but I think it enriches us.
That's a great, almost a summary of what you do and sort of providing your expertise and your medical care in the face of legal, logistical, operational, pharmaceutical challenges of all kinds that perhaps we don't face here, but that young patient in the Philippines faced there in a daily life that we can't really begin to understand because we're not living it, but need some help. And it's a basic human need. So I appreciate that work. That's wonderful work you're doing. What's sort of next for HAEW? How does it grow and where do you want it to head?
And I just want to humbly say, Till, thanks for the compliment, but I think this is the work that ER docs love to do. I think this is where we flourish, where you say, this is a problem. Here's 5 hurdles. Figure it out. This is where we come alive. This is where we flourish. So I just want to say, I just think I'm doing what most ER docs are equipped to do and would love to do. What's next for HAEW? So we are always recruiting for docs because here is the vision. There's 13 million doctors in the world. My first goal is to get 1% of those doctors to volunteer only 2 hours of their time the whole year, 2 hours out of an entire year to do this work. That's enough to onboard and to do a shift. We do them in shifts, really accessible. You can do them from your home. That gives us 130,000 doctors, 2 hours a year, 260,000 hours per year. That is 700 hours every day of physician care that we can carry out through a telehealth connection to the places that need us most across the globe. I'll do the hard work. I'll find the places. I'll do the logistics. I'll do the contracts. I'll do the legal work. But think of the impact that we can make across the world and think about the impact to us as a community. Now we're connected with our colleagues all across the globe. We're learning from them, they're learning for us, we're interacting. We're also learning a lot more about what medicine is, because it's not just what we do in our one little hospital. I think a lot of what we're seeing in burnout right now is what happens when you take this really well-trained, really creative individual and put them in a box and say, this is all you're allowed to do. And we're going to take away any agency. So I think this is where we're going. So that is my first goal, is to get 1% of doctors to join us. We have not only the project in Kenya and Uganda coming up very soon in February, but we have several other areas that have reached out to us organically. Right now, this is just growing organically. Doctors hear about what we're doing. They say, we think you can help us. So things like physical therapy, because patients get into a car accident, they get orthopedic surgery at the main hospital, they go back to their village 4 hours away, and they don't get therapy, so they don't recover appropriately. How can we bring telephysical therapy to their rural clinic so that they can have access to that and learn how to do some of that at home? How can we support EDs that don't have emergency physicians but want to have better ED care? So we do have several projects. And lastly, working with residents and medical students. We're trying to do this in South Africa right now. Because if we can get those learners doing this as part of their career from the beginning, I mean, this is their future. All I'm doing is opening the door to their future. Think of how it changes the future of not just emergency medicine, but all healthcare.
Well, thank you for that. And as you speak about burnout and opportunities, that really fits with some of what we're trying to do at MCentric to build community. And this is an opportunity we would certainly push out and promote among our colleagues, because it really is an opportunity to do something that is potentially very fulfilling and satisfying, and really goes back to the root of why people went into medicine. So this really is nice to have goals that fit together and hopefully can help each other. So tell us again, how can we find you and your work at HAEW, and also your podcast that you do? And we'll certainly put that in the show notes related to this podcast. So tell us how to find you.
Awesome. HAEW is super easy to find. It's www.haew.org. Stands for Healthcare Alliance for an Equitable World. Super easy to remember, HAEW, though. The Voices of Healthcare Equity podcast is available on all your favorite podcast sites, Apple, Spotify, iHeart, etc. And really, our website can link you to almost anything that you want to find out about us. You can contact me directly as well, Dr. T, Dr. at haew.org. A lot of folks like to get that personal connection. I'm okay. I'm still free to do that, and I will connect with you. As long as I'm not in the middle of a shift. If I'm a little delayed, it's because I'm doing a string of locums or something.
Well, that's great. And thank you for joining us today and sharing your perspectives and experience.
Thank you. Thanks for having me. I love connecting with other communities doing great work. We really need to all be working together to help our community right now. I really feel the crisis that our community is in. And I think by helping others, we'll help ourselves as well.
And thank you for joining us in this installment of our MCentric podcast series, The Shift Report. And special thanks to Dr. Kim Tranquada for sharing her important insights. For more content, networking, and innovation in the world of emergency medicine, please visit mcentric.org. And another thank you to our sponsor, Lotus Clinician Wellbeing. Learn more at lotusclinicianwellbeing.com.